Good evening, everyone. For the cardiology session, we have three leading cardiologists with us. The leading cardiologist of Coimbatore, Dr. Vaidyanathan sir. Over to him for the talk.
Let me thank Balamurugan and the other organizers for this opportunity. Having listened to recent developments like gut biology, processed food, so many, and sarcopenia, etc., we are back to basics. We are going to discuss how to control blood pressure in a diabetic. Is there a choice of drug? Should you always be on ARB, or can you use diuretic as the first line drug? And where do we stand? So, increasing incidence of blood pressure or hypertension is something which expect, because aging population, diabetic, so many obesity, all of which will make that more people are hypertensive. And the saddest part is it is silent. For every hypertensive who is diagnosed to have hypertension, there will be 2 or 3 people in the community who don't know that they are a diabetic, and the abysmal controlled rate of hypertension, which leads to cardiovascular outcomes or problems like ischemic heart disease, stroke, renal failure, etc. So vascular diseases are more. We know that even minimal control or reduction in blood pressure improves the outcome in this. So control of blood pressure is something very important. And so most of the, I'm not going to the classification of blood pressure, hypertension, etc. The Indian guidelines tell you that the drug of choice can be an ACE, ARB, CCB, or diuretic, and newer beta blockers. The JNC 8 again says ACE, ARB, or hydrochlorothiazide as the first line drug. Most of the recommendations are the same. There was a time when we were students, diuretic was the first line to be recommended. Then came beta blocker, step care approach came. The diuretics fell out of favor over a period of time because we were concerned about the side effects of hypertension like hypokalemia, sudden cardiac death, electrolytes imbalance, uric acid elevation, diabetes, etc. So this is at present the current recommendation. Start with ACE, ARB, CCB, or a diuretic, and add on as per the blood pressure control. And finally, your aim is to achieve a level which is good. So diuretic can be a thiazide diuretic or a thiazide-like diuretic. What is the difference? The three components, hydrochlorothiazide, chlorthalidone, indapamide. The difference is basically in the duration of action. And you are chlorthalidone got the first place because basically we thought a longer acting diuretic will have a smoother control of blood pressure and the trough to peak ratio will be lower. With the results that it is better. And it also showed that there is pleiotropic effects like platelet aggregation, vasodilatation, so many factors which made it a diuretic of choice. But in spite of all this, the mechanism of action of all these diuretics, whether it's thiazide or thiazide-like, is at the distal convoluted tubule. It acts as the sodium chloride transport. So hyponatremia is the initial, or volume depletion is the initial cause of blood pressure control. Over a period of time, vasodilatation sets in. So in spite of all this, should we always prescribe chlorthalidone or indapamide? Should you move away from hydrochlorothiazide is one big question. Even in the West, the prescription pattern showed that hydrochlorothiazide is more commonly prescribed than chlorthalidone or indapamide. So what are we supposed to do is the question. Evidence of diuretic in CV protection. Let me compare a diuretic with the other group of drugs, not the other diuretics or thiazide-like diuretics. Evidences say that in calcium channel blockers, the outcome is much better with a diuretic compared to a calcium channel blocker. 37% less cardiac failure, 5% less risk of CV events, etc. So definitely the diuretics favor, better. Even in Alhart study, diuretics were better compared to CCB or amlodipine or even AC inhibitor. So there has been a see, the basic problem with all these hypertensive trials are on diuretics are it's not a head-to-head comparison with other drugs. These are all compiled data. That is the drawback of all these data. So primary outcome, based on medical health data, around 4 lakh odd patients, and the events were myocardial infarction, hospitalization for heart failure, stroke, and effective safety outcomes were considered. And what did it say? Compared to AC inhibitor, diuretics fare better in cardiovascular outcomes. And again, the thiazide and thiazide-like diuretics give you a protection from MI 30%, heart failure 42%, risk of stroke is reduced by 22%. I'm a little surprised because blood pressure reduction invariably translates to stroke reduction, especially the hemorrhagic stroke. So my personal impression was the stroke reduction should be much more, but this is the data available. And safety data, there is no drawback for any of the diuretics. Diuretics are as safe as any of the drug or better compared to AC inhibitor, and CCB, whether dihydropyridine or non-dihydropyridine. And safety outcomes, chlorthalidone were hydrochlorothiazide, there was nothing to differentiate. This is the problem. Even though we have some data on chlorthalidone being better, when you do a meta-analysis on these groups, hydrochlorothiazide provides equal or better CV reduction, and the safety outcomes are as good with hydrochlorothiazide compared to the thiazide-like diuretic. And so what do you choose? The diuretic comparison project, people who are on hydrochlorothiazide were shifted to chlorthalidone. A group of people were shifted to chlorthalidone, and it was compared. What were the outcome? The outcome was non-fatal adverse cardiovascular events and non-cancer related deaths almost equal, or hydrochlorothiazide fared better. Non-fatal adverse cardiovascular event, again, head-to-head comparison, chlorthalidone and hydrochlorothiazide. There was nothing to choose between both of them. They were almost equal, or hydrochlorothiazide was non-inferior to chlorthalidone in most of the study. The meta-analysis also showed some of the trials were favorable for chlorthalidone, but the whole meta-analysis said that chlorthalidone is as good in reduction in all causes of mortality, heart failure, hospitalization, or CV outcomes. So when you do a meta-analysis on various diuretics, there is nothing really to say that chlorthalidone or indapamide is better, even though there are individual trials where some of them have shown that this chlorthalidone or thiazide-like diuretics are better. BP control, chlorthalidone was more effective, no significant difference in cardiovascular outcome, but adverse event hypokalemia was more with chlorthalidone. So all said and done, when you really do a meta-analysis of the entire pool data, there is nothing much to, and even in those with a renal dysfunction, understand, the minute you say renal dysfunction and the eGFR is less than 30, thiazide and thiazide-like diuretics are not the drug of choice. So in people with a higher GFR, it was shown that the comparative outcomes were the same. In fact, the myocardial infarction was lesser with hydrochlorothiazide, revascularization requirement was lesser, heart failure was better, atrial fibrillation was better. So chlorthalidone was associated with higher risk of eGFR decline, CV events, hypokalemia. Excess risk of hypokalemia with chlorthalidone was attenuated in participants with reduced kidney function. These results suggest that there is no evidence to prefer chlorthalidone compared to hydrochlorothiazide. Then the fixed dose combination, what is a rational combination? We know the minute we use a diuretic, the renin-angiotensin level goes up. So anything which blocks that will be a better combination. So probably an ARB. We know that one of the ARBs which is so popular in India because of its 24-hour action is telmisartan. So this will be a very rational combination. To summarize, hydrochlorothiazide is an effective first-line antihypertensive for control. Chlorthalidone does not have much of an advantage over hydrochlorothiazide. When you analyze the pool data, combination of telmisartan is a good combination with diuretic.